Good morning, and welcome to this third day of the COVID-19 and Pain virtual program put on by the International Association for the Study of Pain. Today, our 10 o'clock session is entitled The Impact of the Pandemic on Funding, Conducting, and Publishing Clinical Trials, Epidemiological Studies, and Basic Science Research. And we are so happy that you're all here to join us today. Our speaker today is Daniel Claw. He is a professor of anesthesiology, medicine, and particularly rheumatology, and psychiatry at the University of Michigan. He serves as the director of the Chronic Pain and Fatigue Research Center. And until January 2009, he was also the first associate dean for the clinical and translational research within the University of Michigan Medical School, and then primary investigator of the University of Michigan Clinical and Translational Sciences Award, the CTSA. And with that, we will start his video.
I'd like to thank the IASP for giving me the opportunity to talk a little bit about the effect of COVID and biomedical research. This has been primarily a problem, but I'll talk about some of the opportunities that it's presented. I don't think I have any disclosures that are relevant to this talk today. So this is a report from one of the US government agencies looking at worldwide impact of research because of the COVID pandemic. And not surprisingly, the report concluded that worldwide there would be a significant impact on COVID because of various effects of the pandemic, ranging from some inability to achieve original program goals. I think nearly any investigative team had a significant halt or decrease in their research operation during the COVID pandemic. We know that there have been the loss of entire research programs, and I'm going to talk a lot more about this. There's been the loss of ability of investigators to collaborate across institutions. There have been no face-to-face meetings. I'll talk a lot about the potential loss of a generation and some of the individuals that have been particularly impacted in science, trainees, especially foreign trainees. And then some of the other issues, just the costs of ramping up, ramping down as COVID surges occurred and research started, stopped, and then restarted again, including disruptions in supply chains of things like having gloves or PPE or other types of chemicals or supplies that are needed for biomedical research. Often were not available to investigative teams. This was the case worldwide. I am obviously talking primarily about the US experience. But in this report, near the end, it basically said this might provide a new opportunity to identify new practices to facilitate research and reduce regulatory burden. And I've certainly seen this with our research and with our research groups. So I'll talk about that at the end. But the pandemic actually has caused us to rethink how we do things and really do things in a way that might be more efficient, both for research as well as for the individuals that participate in our research studies. You all know, whether you're a healthcare provider or a lay individual, that the COVID infection, the infections themselves were particularly problematic in individuals of color in the United States. And what essentially happened worldwide is that the COVID infection highlighted the stark health disparities within our systems. And we see that poor systems and poor individuals and a number of different underrepresented groups in the United States were particularly hard hit by COVID. But this wasn't just true of healthcare and of individuals who received a COVID infection. This was also true of the biomedical research enterprise. And what's becoming increasingly clear is, just like COVID tended to most harshly affect individuals in clinical areas that were sort of underrepresented individuals with multiple comorbidities. Similarly, the same thing is occurring in the biomedical research enterprise, and that individuals that started off somewhat disadvantaged have become more disadvantaged. This is a really nice article that was written in Cell talking about how the National Institutes of Health and the NIH and other funding agencies worldwide might want to tackle what's happened vis-a-vis training in particular in the COVID pandemic. And one of the figures in there, I really like the text that goes with this figure here, basically saying that the COVID crisis has magnified the systemic issues plaguing academic research, including the excess requirements in publication, tenure and grant processes, the excess reliance on funding from national agencies, and the lack of diversity in academic research due to the attrition of women and racial and ethnic minorities during early career stages. And again, we see now data that this was all magnified by COVID. Individuals in training were having a hard time finding new jobs. I know our group at the University of Michigan wanted to hire several new faculty members, and our department had enough money to do so, but because of institutional COVID restrictions with regard to the financial impact of the entire institution, we and most other academic medical centers have been on hiring freezes for some time. And the individuals that were leaving training positions were the ones that were most affected because we couldn't offer them jobs that they might otherwise be getting. Some articles have looked at this issue of pre-existing biases and whether these were exacerbated by COVID. This is an article looking at first and last author publications in a journal a year before COVID, and then looked at the COVID related publications and showed that there was an increase in the gender bias. There was a 14-point increase in the difference between male and female first authors in the COVID publications compared to the control publications. There's no reason to think that males would be inherently better at researching COVID than females. This is another nice article in one of the Nature journals that talked about the inequities and the unequal way in which research has been affected. And in this analysis, what you see here down at the bottom is that female scientists, younger scientists, and those with young dependents are disproportionately being affected by what's happening vis-a-vis the COVID pandemic the last couple of years. But I want to talk about opportunities and ways in which perhaps the COVID pandemic has forced all of us to rethink how we do research and ways in which we might be able to make it most efficient. This happens to be a study we're involved in which the National Institutes of Health called Backpack. It is run out of the National Institutes of Health. It is part of the HEAL initiative, a broader initiative aimed at both pain and opioids. And this Backpack program is one component of the HEAL initiative that is specifically interested in using a precision medicine approach, and in this case in low back pain, but in general, using a precision medicine approach to phenotype individuals with a pain condition like low back pain, and then identify the individuals who are most likely to respond or not respond to a variety of treatments that we know work in some individuals with low back pain, but we don't know who these work in. So in our particular site at the University of Michigan, Afton Hassett and I are co-principal investigators of the Mechanistic Research Center at the University of Michigan. And in our site-specific project, we are using a SMART design, a multiple randomization design, where we're testing 4 different treatments: physical therapy, mindfulness, acupressure, and duloxetine. And we're really much more interested in who responds to each of these treatments rather than if people respond. And so individuals will first respond to one of these treatments, and then most of these individuals will get re-randomized a second time unless they get a real good response to the first treatment, to a second treatment. And all of the hypotheses in the study really have to do with what phenotype matches with what treatment that ends up responding. But this is a very complicated study, a lot of functional imaging, quantitative sensory testing, interventions that are quite intensive. And so we really had to rethink how we performed the tasks involved in this study to make the participant burden less and to be able to do this study even during the COVID pandemic. So Afton and the rest of the study team spent a lot of time working on turning as many of the activities into remote activities as possible, and now consenting, screening, nearly everything can be done remotely. There are obviously in-person visits for the initial physical exam and bio specimen collection, but more than half of the visits that were originally anticipated to be done in person were moved to remote using different types of platforms and technology. And you see now, again, we are consenting now electronically using Sign Now. We're using a variety of different e-devices to collect data. We've been doing this for a while, but we're getting even more, if you will, aggressive about the use of electronic data capture and using smartphones and apps to collect data. We can also reduce the timing of the assessments that have to be done in person. Again, just really being mindful both of participant burden as well as just being able to run more individuals through the protocol. And even a therapy mindfulness-based stress reduction that had historically been done in person, we have shown that it can be done online. One of our colleagues that's our collaborator working on MBSR has shown that he can get equal results online. This will be done online, and in one of the other backpack studies that we're designing now, a number of the interventions, including acceptance and commitment therapy, will similarly be done entirely online. Not only, again, to make the study easier to do, but to make these therapies more available to individuals after these studies are done. So what is the effect of the COVID pandemic been on research? Well, it's been largely negative. It's had a significant negative effect nationwide and worldwide on biomedical research, every type of biomedical research, especially clinical research, because of the actual halting of entire clinical research operations, certainly at most research centers around the world. Similar to how the pandemic exposed how pre-existing health disparities and lack of access to care disproportionately affected vulnerable individuals clinically, the same thing happened in science and with respect to research training. We see that the most vulnerable scientists were also the ones that are being most negatively affected. But the pandemic did force research groups such as ours and others to rethink how to best perform research, especially clinical research. And because of this, I think there will really be long-lasting changes in the way we do research, especially the use of digital platforms, performing digital trials that might really allow us to dramatically improve the efficiency of some types of research, again, especially patient-oriented clinical research. So thank you.
Well, thank you so much, Dan, for that wonderful talk. Now we are going to open ourselves up for some questions from our audience. We're also going to display some slides to help sort of direct some conversation about the unique problems that our constituency here at the IASP may have had during the pandemic with their own research programs. In this first slide here, we're going to ask the audience about the types of impact that COVID-19 has had on your research in terms of clinical research problems in the lab, problems with funding, and the other unique scientific opportunities that it may have opened up for our members. So please feel free to chime in and ask some questions. And if there are any questions based on Dan's talk, please also put those into the box. Dan, do you have anything you'd like to add now that the microphone is open?
No, not really. Again, I tried to emphasize that although, the pandemic is really quite horrific, it has forced us to reconsider how we do clinical research in particular. And I think we've made a lot of fundamental changes that will never go back. So I do think this has been both sort of an opportunity to rethink how to do research more efficiently, as well as a problem.
I know that in terms of my own program, that we had a lot of problems with our clinical research. Being able to bring in live subjects to study was a very complicated thing at the National Institutes of Health. And it required us to also adjust substantially to create sort of online interviews and questionnaire packets to query our participants about the types of problems they have. We've had all sorts of issues in the lab as well, in terms of bringing people into MRI suites or lab scientists into the lab themselves to perform their experiments with social distancing and mask rules and things like that. Do we have any questions in the box? Not quite yet. So Dan, I know that you have a robust functional imaging program at University of Michigan. I imagine it's still going. Did you have any, were you able to keep things going or find ways to bring in participants?
No, we had several shutdowns. We're back to more or less normal operating procedures now, except people obviously are masked and our employees are all required to be vaccinated. But we had 2 different periods of time where scanning was entirely shut down. In-person research was entirely shut down. So I don't in any way want to minimize the impact. And I think that happened to pretty much everyone in the United States that I'm aware of, had 6 to 12 months over the last, period of the pandemic where they were shut down entirely and unable to really do any research with human participants.
Yeah, we had a similar experience at the NIH with our protocols with being completely shut down. I know that many of the investigators work on extramural funding, and not being able to perform research has consequences on sort of the reporting requirements and meeting the goals that people put forth in their extramural grants. Do we have any audience members that want to talk about that experience? And if not, I'm going to probably ask Dan about how have you handled the needs of your of granting bodies and sort of the pre-pandemic standards that you set for achievement, in the fact that everything was shut down and it was impossible to meet those standards. How has your experience been with the granting agency?
Nearly all of our funding is from the National Institutes of Health, and the NIH program officers have been quite, if you will, forgiving of granting no cost extensions and giving additional time to perform the research. But if you happen to be have grants that you were spending actively, then what you would often run out of is money, not time. So, and the NIH program staff realize this is a problem, but they are not in any way in the position to give everyone that has extramural funding additional funding to complete their studies. So there have been limited additional funds available for some grants to do the work that you weren't able to get done while you were shut down during COVID. But in general, the funding agencies are not in any way able to entirely make those grants whole. And because of that, you end up running a lower number of participants through clinical research studies, or if you're doing laboratory-based research, doing less experiments, because you simply, will run out of money and time.
I really appreciate that. I spoke to a number of program officers at NIH about some of these issues, and it sounds like depending on your program officer or the type of research you're doing, there are different answers for different people, and so it's really there's no one size fits all sort of answer to each person's grant issues with funding. I know that in the U.S. that the political bodies have not moved forward to provide funding to to fill in that gap that Dan just described, the idea that people have have to keep the fires burning, but if you can't do anything, you can't finish your work, and you need that extension. The no-cost extension doesn't keep people hired and doesn't allow you to buy reagents or scanners or coils or anything. And so this seems to be sort of a looming problem. For us, I work and I run a myalgic encephalomyelitis chronic fatigue syndrome project at the NIH, and our inability to bring in participants basically shut us down, and we had to pivot as well, and we went into full data analysis mode. And so we've analyzed countless reams of information, but we had to essentially stop our study at half of its participation, which is, has its problems, of course. One way to deal with sort of those problems of enrollment, we know that our power is not going to be what it would have been if it was fully enrolled, but the idea of using validation cohorts or splitting your cohorts in half, looking at what you have, and then after things are back to normal, recruiting yet another cohort to validate the findings of your first cohort seems like a possible solution to some of the problems that the pandemic has caused. There has been some unique scientific opportunities of the pandemic, and Dan has talked about ways that we've changed our research methodologies that will probably stick with us to make things more efficient in the future. It's also provided a greater interest in some of the things that we study here at the IASP. Pain, fatigue, cognitive fog certainly have a new relevance considering the pandemic-sized long COVID kind of problems that are emerging from the pandemic. Can we go to the next slide? All right, so what are the adaptations that IASP members have made to conduct research during the pandemic? I know that we've been talking about these things already between Dan and I. There are no questions from the audience, and we would love to hear what you have been doing to make things work. At the NIH, there has been lots of different alterations in clinical research methodology. I think about all the pre-screening that are done on our participants that are coming now, that they need to be COVID tested before they arrive, the masking that's required, alterations in how our staff interacts with participants, the use of barriers, masks when we're with patients for extended periods of time. Many people that participate in research like to have family members around or caregivers to help them through the drive them around or help them around, but social distancing has really made that impossible to have support directly with participants, which has been a problem for some. In terms of our laboratory research methods, we have had to go to a shift schedule to keep the fires burning in our bench lab. We are only allowed so many people in space to keep up with social distancing requirements. And so that we have shifts. So the labs that may have been, full of people from 9 to 5 are now operating 24 hours a day, 7 days a week in a shift-wise way, so that everybody can get in and access and do some work, even if it's at midnight. We know that there's been some major issues with getting supplies. The pandemic has created supply chain issues that have ramifications in all aspects of our lives. But in terms of laboratory supplies, getting reagents for PCRs in particular was very problematic early in the pandemic when they were all being rerouted for testing. And even currently, it's many types of laboratory supplies are on back order and are hard to get. And we've had to sort of change our ways so that we can work with our wide collaborators to make sure that people are able to get supplies when they need them, instead of stockpiling them or having our own. In terms of funding adaptations, I think for me in the intramural NIH world, not much has changed in terms of our funding adaptations, but we have certainly looked for new projects in the COVID space to expand our methods into. And our own program has adapted our direction because of the pandemic. We had been studying post-infectious ME/CFS and long-haul COVID, post-COVID problems seem very, very similar to what we were studying. And so we've sort of adapted our program to start enrolling people who have problems after their COVID infections, and have created a phased program that started off as an online telephone interview project and is moving towards bringing individuals in for deep phenotyping. The program, as we've designed it, and this is sort of part of those adaptations, is phased to increase in what we can do as our abilities to bring participants in and do things is increased. And so we're trying to time ourselves to progress what we do with the progress of the pandemic. How about you, Dan? Any other adaptations that you would like to discuss with the audience?
Yeah, I think one of the things you mentioned, Brian, we could probably expand on a little bit, is that I know that the NIH and most funding agencies saw quite an increase in grant applications because investigative teams, because they weren't able to do their research, were doing what you and your team did, is you were analyzing data, looking at data, writing manuscripts, writing grants, because you had more, if you will, free time to do that kind of work that could be done virtually. But that the sort of unintended consequence of that is that it drove funding lines even lower at the NIH because the denominator was higher. There were more grants submitted in each cycle, which meant there were more grants that were triaged. Again, for those of you who are not familiar with the system at the National Institutes of Health, roughly half of the grants that are reviewed in any given cycle are triaged in that they get an initial review from a couple reviewers, but then based on the preliminary scores, they're not discussed by the entire study section. And that ends up being unfortunate for the investigators that put in those grants, because if your grant isn't discussed, you don't get as rich a comments back as if it is discussed. And so what ends up happening is that study sections can only review a certain amount of grants at any given study section. And if the total number of grants that each of those study sections increases by 50% or more, as it did, I think, in a couple of the first cycles, and the numerator increases by 50%, you can't really review any more grants. So that just means more grants end up being not discussed. And again, the investigators are not getting the really more nuanced feedback that they would like to be able to get to make their applications better. So again, I think there've been a number of sort of negative, unforeseen consequences. But on the flip side, our group and others, because we were standing down a bit with respect to actually doing ongoing studies, and we were analyzing older data sets, we wrote manuscripts and analyzed data sets that we might otherwise have just left there and moved on to the next study. So I think that's actually been quite good. I think that secondary analysis of existing data sets, especially by trainees, looking at alternate hypotheses, is a very good use of scientific data. And we certainly did more of that in the sort of COVID era than we would do ordinarily, just because our faculty and our trainees had more time to do that type of thing. So again, I think people were everywhere were trying to make the best of a bad situation by doing things like analyzing data, writing grants, writing manuscripts that maybe they were getting a little bit behind on.
Yeah, I agree with that. I think that the trainees of the pandemic era are going to have so much more experience analyzing data sets and being overseen in that process than they would have been in the real world. Just because things would have been moving forward, and there was so much focus that there was more time for training, and more availability for training because everything was online and much easier to connect with people for these kind of one-off tasks. Yeah, there's other innovations that I thought were interesting because of the pandemic. Not only were people working harder on getting publications out, but the publication process itself is sort of, I think, changed in a fundamental way. Preprints and online publishing has really taken a life of its own, initially to serve the needs of pandemic science. The peer review process is never a speedy process, but the ability to get out information and data to a wide audience quickly, I think has really been reshaped by the pandemic and the preprint process. I've been quite surprised by the amount of impact that this new sort of method has sort of had on the field, and the ability for investigators to get a wide audience for their data. Of course, there is a downside. Peer review has its place to ensure that the rigor of what is done is appropriate, and I think that may have does suffer a little bit in sort of the preprint online publication world. Have you had any experience with that process, Dan?
Yeah, I agree with everything you said, Brian. I actually want to talk a little bit more about implications for training, because you alluded to some, if you will, sort of good implications for training, but I think, there've been, this has really been bad for trainees as well. And what we find in our group is that the people that have been with the group longer had a much easier time during the COVID era, where we moved to Zoom meetings amongst ourselves. But we actually, for the last nearly 2 years, haven't even taken trainees from outside the institution. We used to do that a fair amount, but because we are not physically, our faculty are not physically allowed to be in our offices yet, and we don't have the casual interactions with trainees that we had when in the pre-COVID, we're not even accepting people from outside the institution because we don't think we can give them a good training experience. And it is a lot more difficult to train your own trainees because, again, the amount of sort of casual contact and interactions that you have when you're working, 40 or 50 hours a week in person, you're passing people in the hall, you're going to lunch with them, those things all disappear. And it's not that simple or easy to replace that. Again, what we're finding is that the more senior faculty that have worked with each other for years love this new era. They love working from home more. They probably will continue to work from home more. They haven't found this to be really negative on how they do work. And in many ways, I think many of our faculty will similarly change how much they're in the office versus how much they're working from home. But I think it really has hurt trainees because a lot of our training is, again, I think a lot of the training is sort of casual. It's, you just walk by someone and remember to tell them something or something like that. And that's all gone now when your training is confined to, trainee A, you're doing a Zoom with them every 2 weeks and you're trying to help them and attend to them, but you miss all that, everything in between that you would have otherwise, been able to just different things that come up that help in mentoring and training.
Did you have to bring any trainees on that had not worked with your group prior to the pandemic, during the pandemic?
We have, and again, what that requires then is, certainly for me, I'm doing way more one-on-one Zoom meetings with them than I would have had we been at the office working in person, because when we're working in person, there's more casual, unintended, unplanned interactions. You walk by someone, you attend a meeting, and at the end of the meeting, you talk a little bit about a different study, but all of that is gone. So you have to be more purposeful as a mentor about increasing the frequency of the meetings with trainees. And I find that most of the people that we train in our group are postdocs or further on, junior faculty, physician scientists. Those individuals don't require as frequent interactions as if you're training, for example, a doctoral student. And we do train PhD students in our group, and the faculty members in our group that are more involved in training, for example, our PhD candidates, are, again, that it's a heavy lift to do that virtually rather than in person, because you didn't even realize how much of the training was like sort of casual interactions, rather than pre-programmed, pre-planned meetings that now you're trying to replace that with.
It's been certainly very crazy. We hired some trainees and other employees during the pandemic that we never met in person. And I had one post-baccalaureate trainee who worked with us over a year over Zoom. We had developed what I call the personal development meetings for the low-level trainees or lower-level trainees, because the pandemic is particularly harsh on young people, just to make sure that they were doing okay. But we got to go to the office together about a year after he was hired, and I think I saw him for the first time, and I was shocked by how tall he was. Right, that you can spend all this time in Zoom but not really know anything about certain aspects of people. It's been very interesting that way, and there definitely has been drawbacks. We do have some questions. Erica has asked us, can we mention which changes in clinical trials improved with the pandemic restrictions? Would you like to try that one, Dan, first?
Again, really moving much more aggressively to really flipping and thinking, is there any way this encounter that I had planned in this study could be done virtually via Zoom, via some other platform, via by Qualtrics. We now use an app called My Data Helps for a lot of our studies that really facilitates the collection of PROs and different types of sensor data. But it forced us, we already had been fairly aggressive. We hadn't used paper in our studies for many years. We've been using platforms like Qualtrics, but it actually forced us to move even to the next level. We never had ever tried to do consenting electronically. We never tried to do a visit via Zoom. All of these things were new. We never tried to take an intervention like mindfulness that had always been done in person and see if it could be done via Zoom. And we found that every time we tried to move to a more virtual platform, not only was it fine, but it was often better than the way we were doing things previously. So I do think that it chided, incented, forced people that maybe were putting their finger or their toe into electronic data capture, virtual visits, things like that, to almost think conversely and say, why can't I do that visit? And right now, probably similar to your studies, people are primarily coming in now for collecting a biological sample, like a serum, plasma, urine collection, or doing quantitative sensory testing or functional neuroimaging. Everything else, all the other visits that used to be collecting other data, or all the time that we used to be in front of a research participant collecting data, has now been in some way sort of replaced by a more sort of digital or virtual way of collecting those same data. And what we've seen is that I'm aware of several studies that are going on in our group that when we flipped over to these more virtual platforms, that recruitment increased in ongoing studies. So participants really like this new way of doing research, and it has, I think, been aligned with a lot of efforts led by the National Institutes of Health in the United States and other funding agencies to get patients more involved in helping plan the research projects. When you do that, they'll tell you that they would prefer to open their smartphone every day and fill out a couple questions on their smartphone than deal with Washington D.C. traffic and getting to your place in Bethesda to fill out a questionnaire or a PRO that they can very simply do from the comfort of their own home. So I think it's been nice in that it's been in parallel with us thinking a lot more about participant burden and patient input into our studies. It's sort of allowed us really rapidly to change processes and procedures. And again, I think most groups like ours, and I'm sure yours, are not going back. We're not going back to doing, more in-person visits once the pandemic is over.
Yeah, I have to agree with that. One of the other projects I have is a gene therapy study that had been like ongoing when the pandemic started, where you have people who have received a gene agent and were like halfway through their follow-up. And so we were forced to adapt. How do you follow up people that live in other states that you gave an investigational product to, that you need to understand what happened? And so, we had never done any sort of online virtual visits. And the NIH had to stand up an entire platform for allowing people to talk to participants over Zoom or Teams, and to collect that information and to document it properly. There had to be an entire apparatus assembled to allow people to have blood draws and other sorts of sampling that can be done in outpatient laboratories locally, performed, and have those samples shipped to us. There was all sorts of innovations that made it really possible to do 80% of what would be in a research visit from their own hometowns. And I don't think that's going to change. I think that's a permanent way that people will now probably be requested by granting agencies to increase their efficiency by decreasing the burden on the participants for travel and doing as much as you can virtually when you can. There are some things, as Dan said, you can't get around. You can't do quantitative sensory testing virtually, or at least not yet. But they have ways of sending blood pressure measurement cuffs and EKG leads and things like that. I know the VA has a whole system for doing those sorts of things. And so we may find that expands what can be measured at home to save people visits in this environment. I hope that answers your question. I think there is a second question here. Thank you for this excellent discussion. Did you observe some mental health issues in your trainees? And yes, how did you handle them? Dan, would you like to take the first crack at that question?
The biggest mental health issue that I see in all of our trainees are terrible cases of imposter syndrome, which I literally view. I don't see patients anymore, but I do a ton of mentoring, and each of my mentees has some version of imposter syndrome. So I joke now that the clinical care that I provide is to diagnose and treat imposter syndrome amongst scientists. And that did get worse in the pandemic. Everything sort of got worse. People, just if they started out not feeling sort of confident or comfortable or whatever in their role in science or in their ability to be successful in science, the pandemic didn't do anything good to that. It just made everything worse. And one of the things that I've become very mindful as someone that's led a team of scientists for a long time is people focus a lot on how helpful it is to do interdisciplinary team science to do better science. But I think the thing that's equally helpful and often very underlooked about the value of being in a well-functioning team is it helps buffer people against the failures that this trying to be a scientist, people are subjected to more random criticism from people that are behind the anonymity of the peer review wall. They just get battered with criticism, and it's very helpful. The team is really helpful to protect the person against those manuscripts that get rejected, those grants that get rejected, those things that happen in the field of science very often, more so than almost any other field. And if you're not there in person to tell that person it's okay, we've all been there, we've all done that, you again, you have to try harder yet. And as I thought, what I could or should be doing for our group as we were unable to meet in person, one of the things that I started doing is having social events, outside, socially distanced, mass social events every 2 to 3, just so people saw each other and could socialize and things like that. Because again, I think the social aspect of science and especially the positive social aspect of team science done well is underappreciated, and the protective effect that it has on trainees is similarly underappreciated. So again, I think a lot of that is being lost when we're not there in person, when we're not seeing people, the minute they get their manuscript rejected or their grant rejected, and we have to try even harder to make sure, that we're there for them, and again, help buffer them against the rejections and all the other kinds of things that happen as part of training to be a scientist.
It's certainly a tough time. I have also had issues with my trainees in their mental health, for sure. I think a lot of people who were in transition certainly lost their routines. And at the beginning of the pandemic, I spoke a lot to our trainees about trying to maintain a routine through their lives. A lot of people who sort of move to a new area don't have a robust social support system around them. Sometimes they get involved in sort of suboptimal living situations, or they're in relationships that were just fine when everything was open, but when you're trapped in a small apartment with that person or those people, can create problems. And so I saw a range of problems in our trainees, from anxiety over the events. I saw some risk-taking behaviors. I saw some depression. I saw some adjustment disorders, and a whole range of normal kinds of problems. Not that these are abnormal. This is, the way that people deal with crises and difficulties, is that they have symptoms and problems. And so, you have to try to be there for them and give them a safe space to voice their issues, and sometimes advice on how to do better. What I found is that you can tell people, that it's important to have a routine, that it's important to think about your physical well-being and your exercise, and keep yourself moving, that it's important to get out of your apartment occasionally and change locations, that it's okay to, see other people in a socially distanced way, even at the peak of the pandemic. And, like all things, some people listen and some people don't, and there was sort of varied experiences. I have found that one of the things that probably helped the most with people's mental health in our small slice of it is actually the vaccinations. I think that when people have become vaccinated, in some ways they've become a little bit more confident in navigating the world, and it's taken away a bit of that anxiety that may have been driving some of their behavior and choices. But certainly it's been very difficult for trainees and the people that train them in all sorts of different ways. Let's see, do we have any other questions? Oh, all right. We have a question from Michael here. Are there types of research relevant to the pain field that are now struggling to get funding due to the pandemic? For example, quantitative sensory testing studies requiring frequent blood draws, or imaging studies. So Dan, would you like to take a crack at that?
I don't see that those studies are having any difficulty during peer review getting funded compared to what they were before. I think reviewers are, in fact, the NIH has instructed reviewers of grants to not really insert their opinions vis-a-vis, is this study going to be more difficult to do because it's the COVID era? They've actually specifically asked reviewers not to have that kind of thinking sort of be integrated into their scoring of applications. So no, I'm not seeing that certain types of funding are becoming more difficult to get because reviewers are worried that people won't be able to do it. Again, I think, and it may be that that's in part because the program staff at the NIH had the foresight to actually sort of head that off and say, we don't really want, in general, in the peer review process at the NIH, they don't want reviewers to be like guessing about like, what is this going to happen? Is this going to happen? And they really went out of their way to say, don't now start looking at grants and having, your own preconceived idea of how the pandemic's going to impact that. You do expect the grant writer now to describe what the procedures, so you are trying to minimize, where possible, direct contact with the participant. But again, you're often doing that in part because that also is reducing participant burden. It'll help improve recruitment. That was always sort of looked at as a more positive factor in the past as well. So no, I'm actually not. I guess the simple answer would be, I haven't actually seen that certain types of research are more difficult to get funded because of the pandemic. Certainly all our group really does. Almost all of our funding now involves bringing people in for quantitative sensory testing, functional neuroimaging, and we're certainly not in any way struggling to get funding.
I would even take that a point further. I would say that there are probably more opportunities, that the pandemic has created a variety of pain disorders
Right.
in its wake, that has opened up new funding opportunities that will allow us to take those research methodologies and apply them to a new type of problem. And so I really don't think it's really had an impact either. In fact, I think there may be more opportunities now than there were. All right, hopefully that answers that question. Oh, we have another question from Chris. Are there any indications of increased interest or any significant shift of funding towards chronic pain conditions, generally given the growing numbers affected by post-COVID chronic pain symptoms? Dan, any thoughts?
So the HEAL initiative, which most people are aware of, but some of the international ISP members may not be aware of it, is a large sort of $1 billion expenditure by the National Institutes of Health primarily. About half of that money went to research on opioids, and about half went to research on pain. And it led to the creation of a number of different NIH networks that never had existed in the past, focused on pain. So that did lead to a fairly sizable increase in the overall amount of money that was being spent in the United States, in particular on pain research. And the current budget that is being considered by Congress in the United States hasn't been passed yet, but if it passes in anything like the form that it is right now, there are additional monies for the next couple of years to continue to fund pain and opioid research at that higher level, because again, one of the things that the pandemic has clearly done in the United States is make the opioid addiction problem become worse, is that some of these mental health problems that Brian was alluding to, that in the general population, substance use in general has risen precipitously, whether people have a substance use disorder or not in the pandemic era. Whereas we were starting to see a dip in overdose deaths a couple of years ago, now it's going up again. So the overdose deaths are often sort of deaths of despair. People that end up becoming addicted to substances like opioids are often people that are sort of lower SES background. They're unhappy with their lot in life. They have a lot of mental health problems, and COVID and the pandemic have amplified all of that. And I think people in the US government that are making these decisions about funding realize that it would be a good idea to continue to keep pain research funding at a higher level, at least for the next couple of years. So I hope that happens. I think that'll happen. And these networks that we're involved in, many of these networks, I think they will be really impressive with respect to the discoveries we're going to be able to make, because it really is an unprecedented investment in pain research that never had happened before.
Yeah, so I mean that's one arm of how the U.S. certainly is expanding its reach into sort of pain science. The other issue would be COVID itself is receiving a large amount of funding. And there is an initiative at the NIH called the Post-Acute Sequela of COVID-19 study, the RECOVER study, which is another multi-billion-dollar effort by the NIH to study the problems that follow after COVID. And as they are doing their planning, it is hard to avoid the fact that pain and fatigue and all of the problems that are of our interest are major consequences of COVID-19. And so this sort of represents another way that pain research will probably be expanded in the wake of the pandemic, because there are going to be lots and lots of people that will have ongoing problems after their infections. And so I don't think that we have a real problem with I wouldn't expect any contraction away from chronic pain. I would expect that we'll see an expansion over the next 5 years. All right, I hope that answers that question. Why don't we put up the final slide? All right. What are the types of new or persistent problems that IASP members can expect to experience with research because of the pandemic? So, we've talked a fair bit about the types of problems we've had and the things that we've done, but COVID hasn't really gone away. And we're still dealing with these problems. And even after the virus may be under better control, attitudes and beliefs about that control may not go away for a while too. And so I wanted to put it out to the audience to see what sort of things can we expect, what type of problems can we expect to persist over time because of the pandemic. I will talk a little bit about the uncertain public health issues. It's hard to know how people are going to be able to work in close contact with each other. At this point in time, there's really no clear time window when we can expect that social distancing will go away, when we can work at full capacity next to each other, when people won't require testing to go into places, when people won't require masking. It's uncertain about vaccinations, whether they will be mandated in certain places or not. And without really understanding how people can work in close proximity to each other, it's really hard to plan research. Right? How many people, how much can you really get done if you only can have a certain number of people around? How much can you really get done if taking or doing a participant in your study takes 3 times the amount of time due to the need for testing and cleanliness and social distancing. And so I imagine that the uncertainty of the pandemic will create a continuing drag on the efficiency of in-person research. It will continue to also push people towards virtual research tools, I think. And so a continued expansion of what can be done over the phone, over video conferencing, using electronic PROs and actigraphy and things like that will continue moving along. But uncertainty makes it very hard for planning. Dan, do you see any other persisting problems that may exist in the wake of the pandemic that may take a while to shake off?
I think the thing that'll take the longest to shake off is the effect on trainees. And as I tried to mention in the talk, some of the data, not surprisingly, just like the pandemic hit the most vulnerable people in the population, that we've been talking about health disparities and people that are vulnerable. It's similarly in science, it's also affecting the most vulnerable people, which are the trainees. So I think that's where we have to focus as much attention as we possibly can. Those of us that are in positions where we are training trainees or mentoring or whatever, we just have to be sort of particularly attentive to the fact that these people, more so than, to be honest with you, the COVID era has been wonderful for me personally. And I'm very mindful of that. I mean, I don't have to be in a plane all the time going around and giving talks. And if talks permanently can sometimes be done from your living room instead of in a plane, again, post-COVID is going to be better for me than pre-COVID. So I'm very mindful of the fact that I'm privileged as that I'm an established scientist and an established investigator. And again, at the other end of the continuum, the people that are being most negatively impacted are the very junior trainees and investigators. So I just think we sort of have to just even double down on being attentive to, mindful of occurring with our trainees, because again, that's going to be something that they're going to, the hill just is getting steeper for them to climb.
I agree. I also think that you had referenced issues with funding. I think that there's going to be a sort of this hole. Lots of people have started research and have spent money on their grants and are going to find themselves in this sort of extensions, no funding extensions, and so how to finish your work if no new funding is made available is going to be, I think, another persisting problem, at least for another 1 or 2 funding cycles. I think there was a question in the box here. Let me check this one here. All right, Andrea asks, what to do with trainees, research assistants, or research participants who refuse to be vaccinated, not for medical reasons? I'm enjoying asking Dan to take the first crack at questions here, and so I'll do such again. What do you think, Dan?
It's unusual for me to be at a loss for words because I simultaneously find it like incredibly maddening that we have people that work in scientific teams that don't attend to science and data to make their decision. But I'm also, I live in the United States and I see how some of these people through misinformation and disinformation got to where they are in their thinking. So I'm also, the sort of empathetic side of me, I don't say in any way, I don't ever say what I think. But am I incredibly annoyed that a couple of our research coordinators, had decided that until the university mandated vaccines, that they weren't going to get vaccines? Yeah, I was extremely annoyed, but I didn't let them know that. And I, and again, I think that what's happening in the United States now, including some additional, mandates that came down yesterday from President Biden, is that I think that more and more employers are mandating this, and that it just makes it easier for when it comes like from the government or from an employer. Some of the people that were choosing for one reason or another not to get vaccines are having to get vaccines. And but again, this is, as is often said, this really the continuation of the pandemic, at least in the United States, where we've had ready and easy access to vaccines. The pandemic is a pandemic of the unvaccinated, and the unvaccinated are causing problems for the rest of us that we're more, if you will, socially responsible. So am I annoyed about it? Yeah, incredibly. But when those people are my employees, I'm really careful about how I, choose to deal with it. I'm really happy that this can be dealt with at a higher level, because I do think it would be really difficult as a supervisor to try one at a time to convince these people to get a vaccine.
And I agree with a lot of that. It is it's not possible to change people's beliefs with a short conversation.
Right.
And the mandates that are coming down will address some of this. You can mandate what employees do in their vaccination status, especially in healthcare settings. There's a wonderful precedent for that. And so I would expect that anybody that's working in hospitals or medical research will probably, at least in America, find that these mandates sort of help deal with the issue of recalcitrant employees in vaccinations. In terms of research participants, I don't think that investigators can mandate vaccinations to our participants. And I know that one way that it's being dealt with is just by testing. The idea that you can't participate if you don't have a test. And at the NIH, we at the clinical center, we have the wonderful advantage of having a lab and the administrative desire to ensure that there is no COVID within our hospital. And so all research participants actually have COVID testing before they're allowed to participate. And so it is possible to take that kind of approach to people who want to participate in research and are not vaccinated. Like Dan, I have mixed feelings about it all, but it's important to keep in mind that for people interested in the post-COVID research space, the people that will develop it prospectively now for us as we're ready to study them are going to be the unvaccinated. Those are probably the people who will be of highest research interest today, because they're the ones that are going to develop the problems such as long haul COVID now, not 6 months ago, a year ago. And so, we will be, a lot of our research efforts, if we're really interested in being compassionate and understanding pain and fatigue and these problems, a lot of our work is going to be with people who are unvaccinated or were unvaccinated. And it's important for us to keep that in mind, that these are the people that we're here to care about and to help. And I think that will have to be kept in mind, even when sometimes the desire to pass judgment about social responsibility wells up in each of us, as it does in me on occasion as well. All right, any other questions? I don't see any here in the box. So any other thoughts, Dan? We have about another couple minutes here before we end the session. Any other thoughts about the pandemic's impact on the scientific industry?
A random thought, more of a factoid than anything else, is I have seen a number of industry trials that were markedly affected by the pandemic, and where the fundamental results of the trial from the people that were recruited pre-pandemic to during the pandemic changed just because the nature of the population changed. Or so it's had a tremendous impact on the pharmaceutical industry and drug development. All of those studies, which are often on a much tighter time frame than our studies. You know, we they get NIH funding, get 5-year grants, and we typically will recruit for 3.5 years. The industry studies are time is money, and those studies have been impacted really negatively, and even in sort of bizarre and unexpected ways. I've, as a consultant for companies, seen a couple studies where it really looked like just some of the fundamental changes in people's like sleep and things like that that occurred during the pandemic probably really influenced the results of a drug trial, because it was really changing, you know, if you will, the nature of the population or the condition that was being treated. So if you think we've had problems, the pharmaceutical industry has had even bigger problems.
Yeah, I can imagine that any interventional trial that was trying to show a positive effect prior to the pandemic would have a really hard time in dealing with the environmental challenges on reported outcomes because of the pandemic. It's also, you know, if people who are doing really poorly because of their environment, you can't imagine that medications themselves would change their situations, right? That, you know, there's that old story about the psychiatrist who gave his patient an SSRI and asked how she was doing, and she's like, well, I'm feeling a little bit better on the medication, but I'm still married to the alcoholic. Right. And so, you know, there are only certain things that we can expect to overcome in these trials, and it would be a high lift for a medication to overcome the pandemic. When vaccinations and other treatments that we have developed haven't either. And so I can really appreciate the difficulties that treatment trials would have in this. And it's hard to know when that might change, right? Like when will things be normal enough that the environment won't be suppressing how people feel and interfering with their sleep, interfering with their mood in such a powerful way. All right. Trying to think if I have any last thoughts. You know, I think that it's an interesting time. I think that if people were to advance the science of pain as much as possible now, the pandemic does offer the opportunity of looking at sort of the prospective development of symptoms before and after people develop COVID. And I think that it is a possibility that is out there of seeing how people are, and then seeing how COVID shifts their biology if they develop symptoms. And it's still a possibility because the pandemic is still raging, yet the scientific machine is finally opening up again. And if I were to pick a place where people put their efforts, it would be in the prospective development of symptoms from COVID infection. So I'll leave that out there for anyone to steal and put into practice. Do you have any last thoughts for the audience before we call it a session, Dan?
No, I agree with what you just said, Brian. I think that COVID is it's a sort of a tragic pandemic, but it is a interesting sort of experimental model for our field, because you do have people that newly develop pain, newly develop memory problems, newly develop fatigue, some of the core symptoms we see, in people with chronic pain. So it does sort of, enable us, especially, as you said, I wish the unvaccinated individuals didn't give us the opportunity to continue to study them, but given that they have, we can still look at inception cohorts and people that are newly developing these symptoms. I agree with you. They're both, that work is worth doing, both to help the individuals with long haul or PASC, but also to just better understand pain and fatigue and memory problems and some of the things that we encounter in our, if you will, run-of-the-mill chronic pain patients that develop this without a COVID infection.
All right, well, thank you all for your rapt attention to our session here. I would like to thank the IASP, and I think we will close out the session. Thank you, attendees, for coming. Thank you for your great questions, and we hope that you enjoy the rest of our session.